University of Health and Allied Sciences in Dar es Salaam, Tanzania, and earned his PhD from the University of Bergen. He focuses on antimicrobial resistance and has been a longtime collaborator of both Dr. Anneka Hooft and I as we work together in the Muhimbili National Hospital. And Dr. Anneka Hooft, some of you have been fortunate enough to work with her clinically. She's a pediatric emergency medicine attends both here and in Oakland. She also did her residency at the Children's Hospital Oakland and then did a year with Seed International. She's interested in point of care biomarkers and prediction, as well as the antimicrobial resistance project, which she'll be telling us about today. So this is the tip of the iceberg of what both of them work on, but is a really exciting collaborative project they've done. So come on. You should be able to just advance.
Okay, sounds good. Okay. All right, thanks, Teresa. I'll get started and then Joel's gonna take over. We'll kind of switch back and forth for some of these slides. So just for disclosures, we don't make any money, but this work was funded by a QI grant from Pfizer. We don't get anything else from them, and I'm not selling anything of theirs, so just so for today, we're going to talk a little bit about antimicrobial resistance globally, which I think many people in the audience are probably somewhat familiar with, and then we'll talk a little bit about the burden of antimicrobial resistance, specifically in Tanzania and some of Dr. Manyahi's prior work there, and then talk about a program where we were working on antimicrobial stewardship at Muhimbili, which is a tertiary care center in Tanzania. So as I think everyone has hopefully seen this slide already, I feel like it's been pretty prominent recently. As you can see, the burden of antimicrobial resistance has been increasing, and these are the number of deaths attributable to AMR yearly by 2050. And as you can see in the center in the green is Africa, and the majority of these deaths will be concentrated in Asia and Africa. So not only is the burden highest, but also the mortality per 10,000 population is also highest, particularly in Africa. So this was one of the reasons why we focused our work here. And then again, just to kind of emphasize this, the number of deaths both attributable and associated with AMR is highest in Africa. Tanzania would fall in Eastern Sub-Saharan Africa, so kind of the second highest group, but overall the amount of deaths both related to resistance and directly attributed is highest in this setting. And so there's several drivers of antimicrobial resistance, and we're not going to talk about all of these today. So one of them is consumption of antimicrobials, so overall kind of use. Another one is access, and we'll talk a little bit about how that varies in our setting in a high resource environment versus some of these lower resource settings and how they're regulated. And the last one, which is actually huge and we're not going to touch on today, is kind of the One Health concept and the use of antibiotics mostly preventively in agriculture and aquaculture. And that's outside of the scope of our talk today, but just kind of raising your awareness that that's another huge contributor to resistance. And so drivers of resistance, so one of the big ones is overuse and misuse of antibiotics. So there was a global prevalence study in 2015 that looked at antimicrobial prescribing to patients in over 300 hospitals across 53 countries in the world, including 25 that were considered low middle income or LMICs, and showed that about 50% of inpatients in African countries in the study received antimicrobials, and that rates of what they considered inappropriate antibiotic use, which is always somewhat difficult to define, were high across several regions, so very high in South Africa, Pakistan, China, and then even in the US, in a hospital in Louisiana, they showed that there were a lot of inappropriate antibiotic prescriptions, particularly for acute respiratory tract infections or like what we would consider to be viral upper respiratory tract infections. So it's happening everywhere. There's also issues with access to appropriate antibiotics. So not only is there overuse of antibiotics and misuse of antibiotics for things that don't need them, but there's also issues, particularly in low resource settings for children and adults with actual bacterial infection or high concern for that, that are severely ill, that don't have access to the antibiotics they need or aren't given the appropriate antibiotic. and which we consider essential antibiotics. And so every year, infectious diseases cause over 6 million deaths that could have been treated. So it's kind of a problem on both sides, both too much inappropriate use and then also not getting people antibiotics when they need them. And this slide is a little busy, but it shows that there were a lot of children who are still dying from preventable diseases, and majority of these are caused by pneumonia, and these deaths are strongly correlated with availability of antibiotics. So in this graph, it shows the number of under 5s with pneumonia who received antibiotics, and then on the other side, it shows pneumonia deaths per 1,000, and basically the number receiving antibiotics, the death rates decrease, but also you can see, like in some of these countries over here, particularly a lot of countries in Africa and Asia, where there's a lot of children who aren't receiving antibiotics, and then it shows like these circles by size show that the bigger the circle, the more deaths could have been averted if they had good access to antibiotics. And there's Tanzania. So moderately big circle and a lot of potential for preventing some of these deaths. And so we have, like I said, kind of this balance where we want to decrease inappropriate consumption of antibiotics, but also increase access to appropriate antibiotics to ultimately both treat infections and also reduce the risk of antimicrobial resistance. And so how we track antibiotic use and, oops, our slide got messed up, and resistance varies between high income and LMICs. And so in high income countries, some people are familiar with some of our methods. So we do have established national level surveillance methods. In our hospitals, we use a lot of hospital level surveillance. So this is primarily like EHR driven. So we have like stewardship committees and they pull these data automatically. The pharmacists can pull, what's being prescribed. We have like the little buttons we have to click for the indication and they can look at that. In a lot of LMICs, these data aren't available, so there's just not good EHR systems, or the data that are available aren't really easily accessed or assessed. And then there's not a lot of existing surveillance systems, and so many of these countries have to use point prevalence or case studies where they kind of go in at a point in time and just look at what's being used, and that's kind of minimally expensive because they just pick a period and do it and then leave, or use case studies and kind of aggregate what they have. So now Dr. Manyahi is going to talk a little bit about resistance in antibiotic use, particularly in Tanzania. Oh, sorry, I'm going to talk about this first. So a couple of things just to give you some background on how children are assessed and treated. So most of these visits use IMCI, which is integrated management of childhood diseases or childhood illness. So this is what the WHO has compiled to guide providers through how to assess and treat children with all kinds of things, including acute illnesses and when they present with likely infection. In these environments, there's often a lot of diagnostic dilemmas given the lack of resources. So as you can imagine, there's a lot of overlap in symptoms. So if a child presents with fever, the differential in sub-Saharan Africa is very different than what you would think of for a child presenting in the United States. The available diagnostics are also a lot less than what we sometimes have access to. So in a lot of these settings, primarily in like some of the lower level hospitals and clinics, this is like point of care testing. So usually malaria rapid diagnostic testing, rapid HIV testing, sometimes point of care hemoglobin, and that's it. There's a lot of issues with stockouts or lack of medications and certain supplies that are needed, so oftentimes things are prescribed just based on what's there. Some of these providers, especially some of the mid-level providers, don't have a lot of training or familiarity with pediatric patients and are kind of thrown into a setting where they may be the only provider or put in charge of seeing pediatric patients when they don't really have a lot of experience with that, given the lack of providers overall. And then clinic volumes are often super high. There's shortages of health workers, so they're seeing a lot of patients in a short amount of time and sometimes don't have the time to be able to kind of go through a little more in depth to figure out what's wrong with children, and we'll just prescribe antibiotics empirically. And then we don't actually know the true prevalence of serious bacterial infections in a lot of these settings given the lack of epidemiologic data. So they're also kind of having to guess since we don't really know a lot about some of these places. And then we talked a little bit about this before, but kind of in the access to antibiotics. So in these settings, many of these are what we consider pluralistic health systems. And so there's many places where patients can get antibiotics outside of the formal clinic and hospital settings. So there's drug shops, some of these are accredited, some of these are not, and very informal, like they could be as easy as like someone who's gotten some extra malaria medications and is selling them on the street. There's more kind of formal pharmacies that are staffed by pharmacists, but anyone can go buy medications and you don't have to have a prescription. And then you have your private and also publicly funded health centers. All right.
Yeah, good morning, everyone.
Morning.
I'm happy to be here and to share experience from Tanzania. First, I'll take you through 2 slides, and Dr. Anneka will come again, and I'll proceed. So, I did this study in Muhimbili National Hospital as a point prevalence on antimicrobial use. I did this study in 2022, just looking the pattern of antimicrobial use and indication. So, this point prevalence survey on antimicrobial use is a study which done in 1 day. It includes all patients who are admitted in the ward before 8 o'clock in the morning. It includes both adult and the pediatric. So in this study, I found that 70% of all admitted patients were on at least 1 antibiotic. So it's in line with the finding from the global point prevalence, which found about 50% of admitted patients were on antibiotic. And all antibiotics were prescribed were for empirical treatment. When patient comes before performing microbiology testing, you prescribe antibiotic, but then you need to change antibiotic based on evidence from the lab. But in this study, all patients were prescribed antibiotic for empirical treatment, not based on evidence. And guideline compliance was very low. We have our national treatment guideline, which guide if patient present with these symptoms, maybe a provisional diagnosis this one, you have to give these antibiotics. So we found that compliance to antibiotic to guideline was very low, at about only 45% of patients received antibiotic based on the guideline. And 36% of patients had no documentation of the reason for prescribing antibiotic. If you use the PPS WHO point prevalence protocol, you need to document on indication of antibiotics. So we found there was no documentation why patients were given antibiotic. We know if patient has bloodstream infection, maybe there's indication. If there's sweat tract infection, there's indication. But in provisional diagnosis, there was no indication that patient was given antibiotic because of the reason. And in addressing antimicrobial stewardship, de-escalation is part of the routine on addressing AMR. But we found only 2% of patients switched to oral antibiotic. So they remain on IV antibiotic throughout the course of the treatment. And very unfortunately, microbiology testing was performed in only 5% of patients out of 185 patients who received the antibiotic, and results were only available for 1 patient. So you could see the challenge. I think we discuss later on the challenge which we are facing when we are implementing our quality improvement project on availability of result in the world. So you see, out of 9, only 1 patient had result available. And Tanzania, in combating antimicrobial resistance, The country has developed the National Action Plan for MR. The first plan was from 2017-2022, just ended. And then last year we developed another National Action Plan to combat antimicrobial resistance, 2023-2028. And it has several strategic objectives. One of them is to conduct surveillance on antimicrobial resistance and the research, also to address antimicrobial stewardship program. Facilities should have MOS program. Also, another strategic objective is to improve IPC, infection and prevention control. Another strategic objective is based on increasing awareness, providing education, so that it could address MR. And the last one objective is innovation on performing research, developing new antibiotic. So we are, I think in the afternoon during the ground round, I will give some talk on the work I'm doing on addressing on part of National Action Plan, the activity which I'm doing. I'm part of it, especially on surveillance with the American Society for Microbiology. So Anneka will take you again on a few slides from here.
All right, so yes, now we're going to talk a little bit about our project and kind of some of the challenges we've had with implementing the stewardship program in Tanzania. So as Joel talked about, so Tanzania has their national action plan. The WHO has also been emphasizing this a lot, and so they've put out some different guides for particularly aimed at health facilities and LMICs on how to address how to create stewardship programs and kind of how to combat this problem. And so these are just a couple of examples of those and kind of some of the materials that we based our intervention on. And so one of the things the WHO has done is categorized antibiotics, and they call this the AWARE classification. And so the lowest tier is access level antibiotics, which are considered like commonly available first line kind of narrow spectrum antibiotics that should be affordable and most widely used. So things like amoxicillin would be in that category. And then you have the watch list, which is sort of ones that we shouldn't really be using like willy-nilly, but are important critically for treatment of kind of more serious things, and recommended only for specific limited indications. So one of these would be ceftriaxone. And then you have reserve, which is like kind of your highest like broad spectrum antibiotics that should only be used when everything else has failed. So we think about like things like meropenem, or kind of your like higher level antibiotics. And so one of the things that the WHO has recommended as part of this action plan and toolkit is looking at core elements that should be available at healthcare facilities. And one of these is dedicated financial support, which, as you would think, is probably a little difficult when you're in a resource limited setting. And so they're kind of like, these are the things you should have, but like getting there is another story. And kind of one of the reasons why for this project we looked for external funding to get this going, because there's not a ton of available funding within the hospital to pay for these initiatives, despite, you know, the national plan and kind of Tanzania pushing towards that. And then the other thing is, in this you can see that like the process of getting an antibiotic to a person using it appropriately is very long. And so, you know, it starts all the way from developing the antibiotics to making them, et cetera, et cetera. So oftentimes, you know, some of these things are outside of our control of what we can use in the hospital. And so this project specifically just focused on prescribing, because that is one of the things that we can control. All right, Joel's going to talk a little bit about hospital.
Yeah, so now I'll be discussing our quality improvement project here at Muhimbili, which was funded by Pfizer and the Muhimbili National Hospital. This is the tertiary hospital in Tanzania. It's a national referral hospital receiving patients from all region in Tanzania. It has specialized specialties, and it is also teaching hospital for Muhimbili University Hospital, Muhimbili University. It has 24 hours full capacity emergency. You could see in the picture. The hospital sees almost 60,000 patients annually, and 25% of them are children. And out of those 25%, 60 are admitted. It has a central pathology laboratory, which it has all sections, including microbiology, chemistry, hematology, histopathology, and other lab specialty. But microbiology lab is equipped with the automated blood culture equipment, so it can do automated blood culture, or they perform all microbiological testing from urine culture, wound culture, cerebrospinal fluid culture, all kinds of culture this lab is able to perform. So the MS Quality Improvement Project focused on 4 main areas. First, we tracked antibiotic use and indication at EMD and ward, and then we collected data, microbiology data from the lab. These were mainly data from blood culture and urine culture. We collected this only for tools and fused for wound culture, but mainly blood and urine culture, because these 2 specimens were supported by Fleming Fund. The hospital is part of the surveillance network, and they receive support from the Fleming Fund. Fleming Fund comes from UK government, so they provide all reagent and the consumable to support performing of culture and susceptibility for those 2 specimens. So in the lab, we got the result of culture and the susceptibility pattern for the essence of developing pediatric specific antibiogram to enable the functional of antimicrobial stewardship activity. And then we established the pediatric specific antimicrobial stewardship committee, aiming this committee should be performing AMOS all around, reviewing the result and provide advice on the prescription of antibiotic. And then we offer training to resident registrar at MD on antimicrobial use, and also we developed the poster and educative material both to healthcare provider and to patient, because our study at MD tracked antibiotic use, but we had 2 components. We surveyed healthcare provider and also collected information from the patients. So the first thing, we are able to establish AMOS committee, which included microbiologist. I was among the team, a pharmacist, pediatric emergency physician, pediatric physician, nurse physician, and the registrars. Also, our residents were part of the team. So for this team, we gave them a term of reference on how to perform the activity. All the information which we are collecting, we are discussing with the team, so that hoping that they should use information for quality improvement when the project ends. So on the survey we did at EMD, we surveyed 11 total medical officers, including interns and the residents, and about 87% of them knew the correct definition of antimicrobial resistance, and 74% said they prescribe antibiotic for upper respiratory tract infection at least sometimes, and 80% said the worrying caregivers or patient will be upset if they don't give them antibiotic. They say antibiotic is a quick fix of everything. We are from developing country. When you feel sick, you might go to nearby Anneka projected where we get antibiotic, like this accredited drug dispensing outlet. So you don't need to have prescription. You feel like you have sore throat, you visit your ADO, you get antibiotic, maybe the second day you feel better, and you'll trust that antibiotic which you're given were a magic bullet, but that's not the case. Probably you're having just viral infection, which are very common. And the most could identify empirical treatment for common pediatric condition. And the information from patient, this is a patient who has seen a TMD. Majority of patients during our quality improvement project, which are seen a TMD, were below 5, were under 5, and the men were predominant, and the most they received at least one antibiotic, and the majority of patients which were seen were admitted, and only 1.3% died, and you can see this only 30% were discharged. So we found that approximately 30% of patients who are visiting emergency department were prescribed an antibiotic, and 30% of patients admitted were given intravenous antibiotics, and the greater than 50% of children were given ceftriaxone. This is in watch category of antibiotic. Anneka just has a slide here where WHO categorizes antibiotic. And we found the most common indication for use of antibiotic was lower respiratory tract infections, followed by bacteremia, and prophylaxis was the third, and upper respiratory tract infection was the fourth indication of use of antibiotic. And the most commonly prescribed antibiotic, as I mentioned, was ceftriaxone. You can see in lower respiratory tract infection, almost 84%, 86% received ceftriaxone. For patients who suspected having bloodstream infection, also majority received ceftriaxone. And for prophylaxis, this I'm mentioning medical prophylaxis. Sometimes there were no reason, but it was written prophylaxis. So also ceftriaxone is common. But for same for upper respiratory tract, amoxicillin clavonic acid was common. But overall, ceftriaxone was the most commonly prescribed antibiotic. But interestingly, you could see from this slide. This slide, remember, one of the tasks of the quality improvement project, we are collecting microbiological data from the labs, so result of culture and susceptibility. So this is part of the antibiogram which we developed, and you will find that most of the sensitivity to ceftriaxone was very low, about only 12% of Klebsiella pneumoniae were susceptible to ceftriaxone. You can see Escherichia coli, on 24% of Escherichia coli were susceptible to ceftriaxone, and the Acinetobacter baumannii only 14%. But if you look at meropenem, which is on watch category as well, it was a bit more effective, relatively. About 70% of Klebsiella pneumoniae were susceptible, and the 79% of Escherichia coli were susceptible. But for Acinetobacter baumannii, this is very notorious. pathogen causing healthcare-associated infection. Only 44% of them were susceptible to meropenem. But you can see, for example, for ceftriaxone Y is the most commonly used antibiotic, and the irrational use of antibiotic is one of the main driver for developing antimicrobial resistance. So you can see this is a guideline which is used the TMD for patient with sepsis. So it's one size fits. So all patients with diagnosed sepsis, they are given ceftriaxone and the IV metronidazole. So antibiotics are not prescribed based on the source of infection. It doesn't matter you have respiratory tract as a source, or gastrointestinal tract, or other source. Is one size fits all. So that's the first line is IV, ceftriaxone, and the metronidazole, plus vancomycin if patient is immunocompromised. And second line is treatment is IV meropenem, but result as you see from the previous slide, resistance to ceftriaxone is high, but meropenem is now increasingly used in your setting. So I don't know what's going to happen in a few years to come. Maybe we might see what's happening to ceftriaxone. And then we developed the educative material to both patients, try to educate them on the appropriate use of antibiotic. So this is in Swahili. I don't know if you understand it, but we are trying to describe, to explain to them what's bacteria and what's virus, the difference between virus and the bacteria, and the importance of some of the useful bacteria to our body, like normal flora. What do they do for our health? And we try to explain to them when they see like they're having symptoms, what should they do? Yeah, before taking antibiotic, maybe they need. If you've seen the on my left hand side, it should be right hand side. That's the attempt to explain. If you see like you have symptoms and signs of infections, you should visit the hospital and get tested. And once they do testing, then you are given appropriate antibiotic. But if you just don't follow proper procedure, you visit nearby drug dispensing outlet, you get antibiotic, but as antibiotic which you get are harmful to your body, and there's risk of developing antimicrobial resistance. So I try to explain this in Swahili. So encouraging them when they feel sick, they should seek medical attention before visiting just to nearby drug outlet and get antibiotics. This one was for medical providers. So we are encouraging them to stop and think about 5 Ds when prescribing antibiotic. First, make sure you have correct diagnosis, and then choose appropriate narrow spectrum antibiotic or monotherapy if possible. Start with access before watch and reserve, and then give the appropriate dose to patient age, infection type, and site. And the prescription also should be guided by result from the lab, which supports that this infection due to this pathogen and the specific pattern. Also, duration of therapy, minimize duration of therapy, and the direction educate patient on what to use. I'll take them at home and reason for time for follow-up. So we faced a couple of challenges during the implementation of the quality improvement project. This was funded by Pfizer, but our intention that there should be sustainability. Once grant funding ends, the committee should keep on having the meeting, discuss collecting data, and use data for quality improvement. So one of the challenge which we found, because we are collecting also information from the world, with availability of results, microbiological culture result in the wards. Normal for blood culture, we use automated blood culture system, so it takes up to 5 days for results being out. So clinician should get result either as negative or positive. So sometimes the results were not available for making a decision. So that's why PICO treatment is quite common. Interpretation and translation of result, that is also a major challenge. For example, for us as a microbiologist, we have like expert rule on prescribing antibiotic. For example, in some setting, amino drugs should not be used alone, maybe need to combine with other antibiotic. So lab people, they're supposed to interpret when the acid organism maybe is only susceptible to aminoglycoside, they should advise clinician how to prescribe. Or for example, when you are isolating organism which like Staph aureus, which is methicillin resistant Staphylococcus aureus, and in lab you test only cefoxime, but in interpretation of result, you need to guide the clinician that other beta-lactam antibiotic maybe should not be used in that case. Also, in the ward, we found that de-escalation of antibiotic was not practiced. So, like you saw in my study, which I did, only 2% of patients switched to oral antibiotic. So, patient can be on IV through the course of admission, even if the patient is improving. And we had a challenge also. Initially, we offered training. We provided term of reference for MOS committee, but then we want to provide more education so that there should be sustainability at the end. But then we struggled to have this meeting, and at one time we planned to have presentation of our result into symposium, but I was not around. And said, no, you should be around for this presentation to be made, because I tasked one of my students to make the presentation, but said no. So we had also challenge. Also, with other resource limited setting, microbiology lab reagent and equipment, sometimes we have shortage of reagent and consumable. Luckily, at Muhimbili National Hospital, we have this support of Fleming Fund. So at least during the implementation of quality improvement project, blood culture and culture was supported with reagent. Our quality improvement project covered a fraction of pediatric ward. We covered only 2 wards, so we couldn't perform like MOS round to other ward like oncology ward or hematology ward. So we only constituted 2 wards, ward A and ward B. Also, there's buy-in and commitment from management. For sustainability of MOS program in any facilities, you need commitment from management. Anneka was projecting like financial resources need to be allocated. But in this, during the implementation of MOS program, we wanted to update the guideline, EMD guideline for management of sepsis. As you could see, all patients are given the same antibiotics. So we developed the guideline so that antibiotic could be prescribed based on the source of infection, either respiratory tract infection, either gastrointestinal tract or urinary tract infection. So antiseptic should not be used in all cases. So to date, we haven't been able to update the guideline. We've been fighting back and forth. Unfortunately, our champion Raya and Henry, who are champion at TMD, they are no longer at Muhimbili right now. So other challenges, stock and the availability of antibiotics as well, is quite interesting. You might find patient is prescribed this antibiotic for 5 days, but dispensing is on daily basis. So you go to pharmacy, you're given what is available. Yeah. So day patient may get ceftriaxone, next day amikacin, third day other antibiotic. So that's also one of the challenge which we came across. But also there's change of management. When we started, we have other management, but in between there's no management. So there are a lot of bureaucracy and the administrative support, like buying from the management also is challenging. They've introduced the new procedures in every aspect. For example, also this approval of the guideline needs to go through different procedures. So we are a bit stuck. But we are still pushing to make sure that the EMAT app, because Henry is planning on this, should update the guideline. But ongoing data and ability to track changes, PDS is not performed. So once the grant, the support to Pfizer ended, I'm working with the at Muhimbili University, not the hospital. So it's kind of two different institutions. So, and you can't push just alone. You need to buy in, and you can monitor, track the changes, the effect, like what we did. We developed the antibiogram. We gave them to the ward. Are they implementing, following the guideline? So now to go back and review maybe the case notes. If they change the treatment and clinical treatment is based on the antibiogram which you provide. And also staff turnover. We mentioned our champions are no longer at the EMD right now, so it's difficult to push some initiative which we started. But likely sometimes Henry shows up and Raya when they're available. Hopefully we can get there where we want to be. Yeah, so what's the next move after all this challenge which we are facing? We have unfinished business. We need to conduct this education, MS community education, but this should be like a symposium. We'd like to present our results and share with the hospital at large. And the provide education also in the symposium, like I mentioned. But we are doing follow-up study on cultural results. So it took us quite a number of months, if not a year, to get approval on performing follow-up study on cultural results. So we have a pool of data, more than we collected information of more than 4,000 patients from the lab point of view. So we know this patient is culture performed and the isolate which was isolated, and so its susceptibility pattern. So we want to go back to see the clinical data, yeah. So we know if maybe antimicrobial pathogen is isolated, what was the outcome of the patients in terms of disposition, including mortality, discharge, duration of hospital stay. So we want to link our lab data and clinical data, and then we could see the impact of antimicrobial resistance in this setting. But also revising the guideline and the incorporation into the resident curriculum. So I think this will be finally we get through. We are struggling, but hopefully I will keep on pushing Henry and Raya to make sure we update the AMD guideline and the expansion of the guideline into EMAT, because Henry is still the chairman, and I think once the guideline has been approved at Muhimbili, and then we could incorporate into the EMAT app.
Will you say what EMAT is?
Yes.
Will you tell them what EMAT is?
EMAT, Emergency Department,
Emergency Medicine Association.
Emergency Medicine Association of Tanzania. Yeah. I'm not
You're not part of that.
medicinal cohorts, yeah.
Yeah.
And then we need to offer more advocacy, advocacy on so many aspects, including AMS itself, that it could address the issues of antimicrobial resistance. We need to provide advocacy to management to have buy-in of the initiative which we did. And if we manage to lobby in and understand the impact of a project like this one, maybe, and then you could successfully address the antimicrobial resistance in your country. Yeah, so the committee, now we developed the pediatric specific AMS committee, but the hospital, it has the hospital AMS committee, but they're not meeting regularly. Fine for us, we are successful to have meeting at least quarterly. But then Family Fund, which supports the hospital, perform culture, accessibility, it has received fund for 2 years. So it also wants to build the capacity of antimicrobial stewardship committee so that they should play a major role on taking on or implementing antimicrobial stewardship program at the hospital. You know, we have this committee, but we don't have the team which perform all around. So we expect this committee, we want to build the capacity of the committee. They should be meeting, but we give term of reference to ensure that they are able to advocate to the management that they should perform major round, MS committee, MS round. They should perform a point prevalence survey, like the one which I performed. That should be at least recommended twice a year. And once you have result of point prevalence survey, you should develop collective action, yeah, and use the data for quality improvement. Also, they should play a major role on developing and updating hospital formulary based on the data from surveillance. Also plan for quality improvement intervention based on the support we receive from Family Fund. So the goal to demonstrate success, and then the government or the hospital should take over the MS. They should take ownership of the MS program. Having said that, I want to thank, special thanks go to our partner, Dr. Professor Henry Sawe, Dr. Ra Yusuf, Herbert Mshana was here, I think, last year.
Yeah.
And the MS committee, and the team which supports the collecting data, and the medical student and the resident. And special thanks to Dr. Achi for providing us some guidance with her when we were developing the pediatric anti-program. She was really useful on our quality improvement project. So, asante sana. Thank you. Thank you very much. Yeah.
We'll open it up to questions for those in the audience, and for those who are online, if you want to put your questions in the chat, I'm happy to read them for you. You join us for the lecture later today, which will cover different aspects of the AMR crisis in Tanzania. I have a question for you, Joel. What do you think in a hospital, a tertiary care center like Manyahi, what are the barriers to doing culture in a clinical setting? I think the data you cited or from your study was like 5% had gotten some microbial culture performed or something like that initially. So why aren't cultures being done in a place where there's capacity to do it?
Yeah. So I would say the major barrier could be clinician herself, because we are used to empirical treatment. Initially, has been the trust between lab and clinician maybe wasn't there, because in the past maybe short of out of stock reagent were very much discouraging clinician. So they thought maybe lab was not helpful. So the practice was to treat just empirical treatment. So that could be major barrier. So we need to go back and educate a clinician that we have this issue of antimicrobial resistance, you know, and if we don't treat based on evidence, we just keep on driving the problem much bigger. So there's need to perform culture and susceptibility. So it's easier for someone to do investigation for other disease, like use HIV. You should take a test. If you don't take a test, you can treat someone, you can double someone. Yeah. But if for bacterial infection, they just give empirical, it does work, you change to this one, it does work. And the MRS individual problem, you know. So we haven't really understand the burden of antimicrobial resistance. That's why we are reluctant to perform culture. So we need to go back to basics to our clinician. Yeah.
With the Fleming Fund funding, are blood culture bottles more readily available?
Yeah, so you know, the system is patient they pay out of pocket or from insurance. Every investigation, patient has to pay. So for Fleming Fund, they're providing this for free. Its support is a grant. It has its own challenge as well. It's not 100% perfect, but they are trying to support blood culture and as a consumable for free. So to my experience for the past 4 years, we've been to support consistently the blood culture and as a reagent. And then we see now the desensitization of performing blood culture. I think they see incentive of it, they get results sometimes. The other wards which they feel, they will ask that for culture always. Like ICU, when we were doing a study with our students, she was providing feedback. So we always ask for culture result. So the essence of the Fleming Fund is just to sensitize. Yeah, the management, the facility to see the importance of performing culture. Yeah, and they can use the evidence for patient care. So if we can this practice, maybe then they will see the role of performing testing always. Yeah. You had a question, yeah?
Yeah, if a mechanism or a pathway to stewardship is like the wait and watch method, like if these symptoms get worse, if you develop a fever on top of these, then do antibiotics. If we think there's a bacterial infection on top of the virus, then do antibiotic shifts. But what does follow-up look like in Tanzania? Is that a reasonable way to wait and see? Will patients come back if they get worse? Or is it sort of the idea of they're here in front of us and so we need to optimize treatment by starting antibiotics now because they are here, they are present, they transported here, and as opposed to waiting and watch or having them come back?
Yeah, so all the mechanism of follow-up is there. So for example, Mwimbi, we see where I'm working is tertiary facilities. Yeah, so most of patients are referred from other facilities. There are very few private, maybe private patients whom they come direct from home and direct to hospital. But always, sometimes the mechanism for follow-up is there. You see patient and you ask them to come back after maybe a couple of days, but the facility itself is too busy sometimes. So maybe you might be given long follow-up time might be long. So patients, there's a possibility maybe they might go to other facilities. But here, I could argue sometimes people think let's give antibiotic, give everything, so that you could sort for all. Yeah.
What about the turnaround time for cultures? Like if you want to narrow an antibiotic, how long would it take to see what is growing or what is sensitive?
Yeah, so it depends with the type of culture. For blood culture, maximum is 5 days because we use automated blood culture system. For wound culture, turnaround should be 3 days. The same as for wound culture and the spot track system specimen, because the system which you are using for blood culture, the blood culture can stay in the machine for maximum 5 days and then gives. If it's negative, and then you know that blood culture is negative. But if it's positive the first day, normal patient will get result in 72 hours. Yeah.
Is it sooner than that they get like the initial result?
So it's
The earliest they can get a result for like a blood culture.
yeah. So if you follow the guideline SOPs on giving feedback, because if there's growth on the first day, you need to report, right? Give preliminary results. For example, it's gram stain result, is gram positive, gram negative. So you could modify your treatment based on the initial these results. If gram positive, if a patient you are giving maybe coristin, you should say no, coristin does not work for gram positive, and then let's move to gram negative to other antibiotic. Second day, you might get colon. You could describe colon. You need to share with clinician. Third day, you have ST result, and then you give feedback to clinician. But sometimes there's this lapse. Term reporting is not practiced. Sometimes there'll be delay. They will report results until they have ST result when they share result to clinician. But I've seen now clinician they've been motivated. There's still change, especially in like neonatal unit. They'll request for preliminary results. So they've seen the incentive of performing blood culture. I think it's been helpful, especially in neonatal ward. I see sometimes clinician will call, although we are at university, they will ask even the sample if they have patients who are very sick, maybe they will ask even to perform in your university lab, so that they can always reach you and ask for preliminary results. Yeah.
Dr. Rachel Wadier, who's online, has her hand raised. Rachel, do you want to come off mute and ask your question?
Yes, thank you. Thank you so much for this presentation. It was excellent. So I have been an antimicrobial stewardship clinician here in San Francisco. I work with Dr. Singh a lot, and I think many of the challenges that you all have articulated strike me as challenges that we also face in relatively well-resourced stewardship programs. So just solidarity, but also that many of them are exacerbated by the less resourced setting. I have now heard from other programs, though, in similar settings, and some programs also with funding from the Fleming Fund who are developing antimicrobial stewardship programs. And I'm wondering if there is any current peer support network to learn from other programs in a similar situation who are dealing with some of these same challenges. because that's been one of the best resources for us doing pediatric stewardship in the United States, is just the opportunity to connect and learn from other programs who have had some success.
I didn't get to a clue. She was asking, I didn't get the last part.
Oh yeah, just the peer support network, if that is something that is established yet, to your knowledge.
Like, does the African CDC have like an AMR network
Or part of Fleming Fund, like is there
Yeah.
like something where you can talk to like Kenya or like other people doing?
Yeah, so first Fleming Fund is country grant support so many countries
Mhm.
in Africa, not only Tanzania. They are supporting Kenya, Malawi, Uganda. I think they have all region in Africa, East and Southern. They have, I think, 5 or 6 countries, including Zambia, Mozambique, Zambia and Malawi, Uganda, Kenya, and Tanzania. Also in the other African region. CDC Africa, also they have this initiative. They are supporting like surveillance, and they have network. They called there's network of laboratories. I think they are supporting surveillance. But also we have EXA, this East African Community Network. Also they are supporting some of the antimicrobial resistance initiative, like they are offering education to some of the facilities, like adherence to aware classification, developing AMOS programmed facilities. But the major challenge in this facility, they don't perform culture and the susceptibility. So implementing MOS without performing culture and susceptibility also is quite challenging if you don't have lab finding. Yeah, you want to develop antibiogram, you don't have a lab finding to support development of your antibiograms. Yeah.
And do you have like is there any connection between these? Like, can you call, or do you have meetings? Like, can you ask somebody who's like implemented a stewardship program in one of these places, like some of their advice, or like do you guys talk to each other? I guess that's what her question is. Like, is there like a network of people within this that you can kind of like,
in our country?
yeah, like no, like outside. Like, can you exchange ideas with other places that are doing
Other
similar
country?
work? Yeah, in Africa.
No, we don't have that kind of network so far. Although in our country we have, on our National Action Plan, we have technical group working on each area. So we do discuss funding from other facilities. And for us, as I'm consultant for Anneka consultant for microbiology, which is a lead grantee for the Fleming Fund in the country. So we do have like eco platform where we could discuss finding from other facilities. If we have difficult case, they might present and offer expertise opinion. But from other African networking, we don't have that kind of networking so far. Yeah.
Thank you very much for your talk, and just to also promote the 1 o'clock talk that you'll be giving. I think it's just down the hall in a slightly different room, but please join us. Thank you.
So asante sana.
Yeah.